Continuing on here in our discussion about a differential diagnosis related to ischemic heart disease. So we're saying, in other words, what they have is ischemic heart disease, most likely, but what are some other things that could be causing this chest pain? Okay, just because their chest is hurting doesn't mean that they automatically have ischemic heart disease. We already talked in previous videos about what actual ischemic heart disease is and what causes it. And then we talked a little bit about pericarditis as a differential diagnosis. And we also talked about aortic stenosis related to a differential diagnosis. Now we're going to be talking about some other vascular causes of chest pain that might be on a differential diagnosis in the case of someone who is presenting with ischemic heart disease. The first of these is going to be acute aortic syndrome. And the quality of acute aortic syndrome is going to be a sudden onset of unrelenting pain. In other words, just all of a sudden, it hurts really bad and it won't stop. They might describe it as being like it's tearing or ripping, almost like they're being stabbed with a knife. Typically, the patient's going to have anterior chest pain, which is chest pain in the front, and it may even radiate to their back between their shoulder blades. This person who has this is often, you're going to notice that they have hypertension and some kind of connective tissue disorder. There's a number of different connective tissue disorders. We won't go into that right now. They might also, when you listen on auscultation, they may have a murmur of aortic insufficiency, and they may even have loss of peripheral pulses when you go to check their pulse here. So that's the first one, acute aortic syndrome. Another vascular thing that should be on your differential diagnosis for someone who presents with ischemic heart disease, it should be a pulmonary embolism. Remember that a pulmonary embolism is usually caused by stasis in the lower limbs, the veins of the lower limbs. And remember, if everything from the lower limbs, or excuse me, all venous blood is going to go to return back to the lungs to be oxygenated again. Therefore, it's very likely that the embolism is going to be a pulmonary embolism or an embolism in your lungs because it's coming from your deoxygenated blood. And usually what happens is somebody will sit for a long time and the blood will kind of pool and sit for a long time and start to coagulate, and it'll make this little thrombus, which becomes an emboli, breaks loose, and gets stuck somewhere in the person's lungs. What happens is just all of a sudden, they'll have this, chest pain, and it's going to be pleuritic, or pleura means like, just lost it. Look up the word pleuritic. I'm going to have to in a minute. It may manifest as heaviness with massive, excuse me, I'm just tripping on my words here. It says it may manifest as heaviness with massive pulmonary embolism. If the person has a really big pulmonary embolism, it may even feel heavy in their chest. Usually it's going to be lateral, which means it's going to be kind of to one side or the other, whereas remember acute aortic syndrome was kind of more here in the anterior chest or maybe the back. And so whatever side is hurting more is probably the side of the pulmonary embolism. The patient will have dyspnea, which means shortness of breath, tachypnea, which is where they're breathing really fast, tachycardia, where their heart is beating really fast, and hypotension. So let me kind of explain what's happening here with the hypotension and tachycardia. So your heart has some different methods of measuring the amount of pressure that's in your system. And if your heart senses that you don't have very much pressure, then it's going to try to beat harder and faster to try to get blood where it needs to go in your body. Okay, it's actually your brain has a lot to do with this. But anyway, I'm not going to go into the physiology right now. But basically, just understand that when you have a pulmonary embolism, blood is being blocked from going from your lungs to your heart, and so your blood pressure is going to drop because it's not going to your heart. If it can't go to your heart, then it can't be pumped from your heart, which is what determines your blood pressure. So your heart compensates by beating really fast, and when you check the person, they have really low blood pressure because everything's backed up. Less blood return back to the heart. Okay, another vascular issue associated with a person who presents with ischemic heart disease that should be under differential diagnosis would be pulmonary hypertension. We won't go into too much detail on this, but essentially it's lung hypertension. So or at least the vasculature in the lung is very high pressure. And this can happen for a number of different causes. But typically the person is going to present feeling pressure. And usually what's going to cause it to happen is going to be some sort of exertion. But in other words, they're like exercising or something like that. The pain is going to be substernal. So here's their sternum, so underneath their sternum. And they're also going to have dyspnea, shortness of breath, and signs of increased venous pressure. Okay, remember you have your arterial pressure and your venous pressure, and so their venous pressure is going to be increased, which, remember, it's the veins that are going into the lungs, because they're deoxygenated blood going into the lungs, and so that venous pressure, everything's backed up because you have pulmonary hypertension. It's really lots of pressure in the lungs, and so that's backing up into the veins, and so you have increased venous pressure. Okay, so that was some vascular things associated with our differential diagnosis of ischemic heart disease. But what about pulmonary causes? So a person comes in, they've got chest pain. It could be pneumonia or pleuritis, which is inflammation. Anyway, we'll go back to that. What I was talking about earlier, the pleuritic, there's pleura, cap. Anyway, so the onset and all that stuff like that can be kind of variable in the case of pneumonia and pleuritis. So we won't go too much into that, but it's usually on one side, and it's usually kind of localized to some specific area. The person who is probably going to have a cough or a fever, rales, however you pronounce that word, and maybe an occasional rub, and dyspnea, which is a shortness of breath. So put that on your differential diagnosis, but depending on where it is and stuff like that, you can kind of sort some of these things out as far as your more likely diagnosis, differential. Next is a spontaneous pneumothorax. So pneumothorax, basically, my understanding of it is that you have an area in here, and your lung is essentially kind of being, there's like a cavity that's open on the side, and it's filled with air or water, and it's pushing everything over, and so it's going to be lateral to the side of the pneumothorax, so, pushing everything over to that other side, and the person's going to have dyspnea, decreased breath sounds on the side of the pneumothorax. When you go to listen on the side of the lung, because there's something kind of obstructing the lung, wherever it is, the breath sounds are going to be decreased. And that also will kind of present with a sudden onset. But, if someone comes in with chest pain, doesn't mean that it's even vascular or pulmonary. It could even be gastrointestinal, neuromuscular, or it could even be psychological pain. So let's talk a little bit about some of the gastrointestinal causes of chest pain. Sometimes people have something called esophageal reflux. This is where essentially they're vomiting stomach acid up into their esophagus, and it's burning them, and it lasts 10 minutes, 60 minutes, and it's kind of this substernal epigastric chest pain, and it's worsened by postprandial recumbency, and it's relieved by antacid. It could be esophageal spasm, where the thing just tightens down, their esophagus tightens down. It could last 2 to 30 minutes. And they'll feel this kind of pressure and this tightness, almost like it's burning. And the pain will be, again, retrosternal, just all in the same kind of area. And that would be behind the sternum, yeah. And it can also really closely resemble angina, which is associated with ischemic heart disease. So they should be under differential diagnosis for it. A person could also have a peptic ulcer. Ulcer is like a little hole that's been burrowed there, and this is the same kind of area. It could be prolonged 69 minutes after a meal, cause some burning, epigastric substernal pain, and relieved with food or antacids. Or it could even be gallbladder disease. This would have kind of a prolonged duration, and it would be kind of an aching, almost colicky pain. The epigastric right upper quadrant is where you normally see this. So if you've got epigastric and you go right upper quadrant, usually you're going to be up here somewhere. And it may sometimes even go to the back, and it would probably follow a meal. So goodness, there's lots of different differential diagnosis. Ones for the neuromuscular differential diagnosis would be something like costochondritis or cervical disc disease, or it could be some sort of trauma or strain, or it could even be herpes zoster, or maybe it's just a psychological cause, like emotional psychiatric conditions that would cause this person to feel these sorts of pains in their chest that could just be occurring in their head. So there's a lot of things that could cause or could be on our differential diagnosis for ischemic heart disease, besides the one we talked about in the earlier videos.